And I want to challenge us all today to look at some of the more serious problems facing American healthcare. And I want to challenge you, I'm going to say some provocative things, because I think that we can get through these challenges in a way that is truly historic, but not if we keep thinking in the same ways that we've been thinking. We sort of have been just going down ruts in a road. So I want to challenge us. I am a proud member now of the Providence Health and Services organization, a truly phenomenal organization. I'm also a proud faculty member at Dartmouth. I'm speaking today because I am going to be provocative, first and foremost as an individual, as that husband, father, change agent through all of my career, and hopefully as a colleague of all of you. I have to stay at a high level today and sort of give us a sense of what's possible. I'm going to try to do a really good job so I get invited back to continue this dialogue in future years. I want to start where I think we are, which is in a bit of a crisis. This is a photo I took at the Pacific coast. You've seen this before, tsunami hazard warning, right? In case of earthquake or disaster, go to high ground. Well, I would submit that there are two tidal waves that we're living through, facing us today. One is the silver tsunami, right? The tidal wave of aging. We used to call ourselves baby boomers, but now we're the silver tsunami. I was taught in high school it could never happen. There could never be more older people than younger people on the planet, but it's happening, frankly. The second and related tidal wave is the tidal wave of chronic illness that is rising and is affecting all of us, all of our health systems, all of our communities, right? We invented chronic illness in the 20th century. People used to die quickly of heart failure, boom, you were gone throughout human history. When I was practicing emergency medicine, and I did for almost 15 years, I would admit 2 or 3 people a day with heart failure. Some of them, I'd put a tube in their throat and send them to the ICU. But within a few days, they were out and back. When I was growing up, kidney failure was a reliably fatal disease, right, condition. Nowadays, we have 2 or 3 renal replacement therapies. Cancer was a subacute diagnosis. Nowadays, 60% or more of people with solid tumors are cured. And those we cannot cure, thankfully, live for many months, sometimes years, and through all of that time, most of that time at least, their quality of life is quite good. The problem is that as we use and apply the miracles that modern medicine has given us to extend life and make life better, it's important to recognize that we have yet to make even one person immortal. Which means that we still have a problem when it comes to taking care of particularly seriously ill people. Now, I'm going to refer to this study multiple times. This is the Crossing the Quality Chasm, published in 2001. The IOM committee that produced this was chaired by none other than Don Berwick. It's an important piece of truth-speaking. Talked hard about the fact that American healthcare, for all of our scientific prowess, has a quality chasm. And in fact, that quality chasm is really deep when it comes to people with serious illness and chronic illness and incurable illness. Right? It's not that we're ill-intended. We in healthcare, certainly clinicians, but all of us in healthcare, want to do the right thing. We actually get close to the patients, the people who are our patients. We love many of our patients. And we think that the worst thing that could happen is that one of them would die. But those of us who've been in healthcare know that there are worse things than having someone you love die. There's having someone you love die badly, suffering as they die. In fact, it's also an area of the highest cost. I just saw an article the other day, 57% of all healthcare costs, Medicare and non-Medicare, all across the board, is consumed by people with 2 or more chronic conditions. Most of them, in fact, are Medicare age. But this is an area where the value equation is upside down. And in fact, the IOM has basically concluded that there's a public health crisis that surrounds serious chronic illness and terminal illness. Nowhere is the quality chasm as deep or as wide as when it comes to patients who go on to die. These same problems, documented in the 2014 Dying in America report by the IOM, looked a lot like the 1997 IOM report called Approaching Death. As a medical educator, I'm embarrassed to say that we haven't corrected some of the deep deficiencies in medical education that the IOM has been calling for in literally 6 reports over the last couple of dozen or so years. And it's not just academics. Now The Economist has published its second global assessment of quality of death and dying, or quality of end-of-life care. Guess what? We ranked highest in costs, of course, per capita cost, and ninth in quality. We have a problem. The public knows that this isn't just for academics and policy wonks. Just after that last IOM report, Dying in America, was published, the New York Times opined Americans are justifiably worried about obtaining the best possible care and the care that they really want, as they and their family members near the end of life. All too often, the care is shoddy or contrary to the patient's wishes. You know, at Providence Health and Services, one of the wonderful things that about it is that it really is truly mission-driven. We wrestle with the mission and core values and try to apply that in the rough and tumble world of American healthcare today. We, in our mission statement, it says, we reveal God's love for all, especially those who are poor and vulnerable. How cool is that? To have love right in the title, right in the mission statement. But you know, you don't have to be poor to be vulnerable. You may remember this guy. He was not poor. But if you remember, Steve Jobs developed pancreatic cancer, same disease that took my father. Steve Jobs got the best cancer treatment available on the planet. After neoadjuvant treatment, he went to Tennessee, became a Tennessee native so he could get, or resident, so he could get a liver, got a liver. Lived about 5 years, developed the iPad during that time, thank you very much, the iPhone 5. But when it was coming to the end of his life, he was developing or experiencing some of the same problems that I see day in and day out. Let me quote from 2 paragraphs at the latter pages of Walter Isaacson's book, Steve Jobs. Quote, the following Saturday afternoon, Jobs allowed his wife, Powell, to convene a meeting of his doctors. He realized that he was facing the type of problem he never permitted at Apple. The treatments were fragmented rather than integrated. Each of the myriad maladies was being treated by different specialists. Oncologists, pain specialists, nutritionists, hepatologists, hematologists, but they weren't being coordinated in a cohesive approach. Quote from Powell, one of the big issues in the healthcare industry is the lack of caseworkers or advocates who can be quarterbacks of the team, she said. This was particularly true at Stanford, where nobody seemed to be in charge of figuring out how nutrition was related to pain care and to oncology. So Powell asked the various Stanford specialists to come to their home for a meeting, and that meeting resulted in a new plan for dealing with the pain and coordinating the other treatments. Folks, if Steve Jobs and his wife Powell had to convene a meeting of the Stanford specialists in their home to coordinate care, the question is fairly asked, what chance do the rest of us have? Right? This truly is a crisis. And I titled this, Transforming Care for the 21st Century. Transformation is possible. I submit this is one crisis that you and I couldn't solve in our lifetime, in our work life. I promise you, we have the money to do it, we have the expertise to do it right now. But it will require the ability to see opportunity within crisis. In fact, the opportunity is to routinize highly personalized care, care that people actually want, outcomes that they actually desire, given the difficult situations that human life encompasses, right? That quality chasm still exists. What I've challenged Providence with, what I'm challenging American healthcare with, is that the most dangerous way to cross a chasm is in 2 leaps. We do not have another 25 years to invest in incremental change. Those tidal waves will drown us, meaning they will drown not only our companies and our patients and families, but all of us in our personal lives, our friends, the people we know and love. So let's talk about how real transformation is possible. It's not only a policy issue. In fact, policy has an important role to play, but it has to happen within a much larger context. Let me zoom all the way back and say that it requires right understanding and the use of language. That's where it starts. Almost 3 millennia ago, Confucius said, the beginning of wisdom is to call things by their proper name. That's where we get things wrong. For years, we've been teaching medical students and nursing students that the fundamental nature of illness is medical. We have problem-oriented medical records, right? We, list problem lists as the table of contents of a new patient's chart. Under each of the problems on the list, we teach medical students to soap their notes, create subjective, objective information, assessment, and plans. Heaven forbid we do anything that doesn't respond to a problem on the patient's problem list. But this is wrong. I would assert that the fundamental nature of illness isn't medical. The problem is that if you call it medical, you bring medical tools to the job, right? You ever try to tighten a screw with a hammer? You can be smart. You can be earnest, well-motivated. You can be persistent. You can get a really big hammer, and it's likely you're going to make a mess of things. That's exactly, the analogy is so close to what we do now in our hospitals. I've been complicit myself over the years. We love our patients. We don't want to see them die. So as they get sicker, with the assumption that the worst thing possible is that they would die, we bring ever more powerful medical tools, intensive tools. That's why 20% of Americans spend days in an ICU before they die. That includes people with dementia and advanced cancer and far advanced heart failure. 70% of Americans still die in institutions, either hospitals or nursing homes, where ironically 80% of Americans consistently say they want to be at home, surrounded by people they know and love and who love them. Something is seriously wrong. It's not ill intention at all, quite the contrary. It's that we're calling things medical and bringing medical tools to a job that isn't medical. Illness is personal. Every time I open a new memoir by a physician who's talking about his or her own illness or the illness of a spouse or family member, within the first few pages they say, after the diagnosis, I realized this is personal, intensely so, right? And when you realize it's personal, you actually can bring tools to the job that include the medical. Of course, illness and dying are partly medical. But you can do it within a context that actually addresses the real needs of patients and families. These days, I'm teaching medical students not to start a conversation with a patient saying what's the matter with you, but what matters most to you. This is goal-aligned care. That's the hope that we have. Illness is personal, and not just for the person we identify as a patient. Because we know, when someone you love is seriously ill, you get that illness too, right? It's inevitable because we're connected. The human condition is a connected condition. So let me start talking about hard truths. Don Berwick's panel in 2001 finally gave us a taxonomy for quality. Before that, if you were famous enough either as a physician or as a health system, you could buy billboards and buy ads. You could assert that you were the best, and everybody believed you. Who would counter that? But we finally now have a taxonomy for quality that has been used since this time by all of our specialty boards and AHRQ and NQF to drill down and provide granularity. We know now that treatments have to be safe, effective, patient-centered, timely, efficient, and equitable. And thankfully, they drilled down into patient-centeredness. They said, it's about a partnership. It's not just about valet parking. They didn't say that. I'm saying that. It's not just about being able to choose your dinner off of a menu, which is a very nice thing, or having nasturtiums on the plate when it comes. That's nice. But it's really about a partnership among practitioners, patients, and families when appropriate to ensure that decisions respect people's wants, needs, and preferences, and that patients have the education and support they need to make decisions and participate in their own care. Quality requires that partnership, that shared decision-making. This is not ancillary, it's core. When I practice and see a new patient, I found that the things that would come out of my mouth for years, for 3 decades, were this. I just started writing it down. I want to make sure that you receive the best care possible. In addition to the treatments for this disease, that includes attending to your symptoms and your sense of well-being. In focusing on your physical health, I don't want to ignore how this illness affects your personal life, your hopes, your fears, your feelings, and as well as those of your family. I use that phrase, the best care possible, because it's the only thing I know every single person I meet wants. When you or someone you love is seriously ill, you want the best care possible. But what it means may be different from one person to another, because illness isn't just medical, it's personal. That means that I can't look at a disease treatment algorithm or best practice guideline and know what the best care is for any individual. I have to have a conversation. I have to know what matters most to them. So let's get serious. Transformation is going to require honesty, courage, determination, gumption, right? I said earlier that the beginning of wisdom is to call things by their proper names. So let's talk about bad care. Patient in an ICU, been there for 3.5 weeks, has multi-system organ failure, is intubated and sedated so he doesn't buck the vent, has 2 antibiotics running and an antifungal agent, occasionally has pressors to raise blood pressure when the blood pressure gets a little soft, has CVVH or renal dialysis at the bedside, because kidneys aren't working very well, has a vac dressing whisking away infected fluids. If that patient's family has not had a formal goals of care conversation in the last 10 days, I'm being generous, to discuss with them what are the achievable physical outcomes, survival outcomes, functional outcomes for the long run, and whether it's still consistent with what they want and the patient wants. If that conversation hasn't happened in the last 10 days, that's bad care. It doesn't matter that it's common. I can walk through any academic medical center's ICUs and point to several of these patients on any given day, but it's bad care. It's way out of compliance with best practice guidelines from the disciplines that are practicing there, the Society for Critical Care Medicine, the AACN, the American Thoracic Society. They all talk about the importance of goal-aligned care and the critical importance of those family meetings to discuss what's achievable and whether it's still wanted. In fact, the IOM, in a sense, gave us a taxonomy for bad care back in 2001. It's care that's unsafe, ineffective, non-patient-centered, untimely, inequitable, or inefficient. Nowadays, we have the Choosing Wisely campaign convened by ABIM, which has asked all the specialty societies to list things that they consider to be unwise or need to be challenged or not used. Because of the being a palliative care doctor these days, my list includes recommending PEG tubes for people with advanced dementia. It doesn't work, doesn't extend their life, doesn't help with decubiti. It just makes their life miserable and medicalizes something that is entirely personal. Multiple fraction radiation treatment for bone metastases. Every study that's looked at this says it's not necessary. A single fraction does as well. It's more costly and it puts people through misery. We can get beyond this, but it's going to require conversations and preparation. Goal-aligned care is the pivot around which we need to transform healthcare. If we're not giving care that people want, why are we doing it? But in America, those conversations are hard to have because it's always too soon until it's too late. I don't want to talk about it. Can't we please talk about something more pleasant? You're probably thinking that now. So those of us who practice in acute care settings sometimes meet people in the ICU or when they're sedated or in extremis, even though many of these patients have been sick for many months, sometimes years. They may have congestive heart failure and been in the hospital multiple times, or COPD with multiple exacerbations, or metastatic cancer, but nobody's had that conversation. Their primary care doctor thinks the cardiologist or the oncologist is having it. The hospital medicine doctor doesn't think it's his or her job because they should be done by the disease line specialist, the cardiologist or whomever, or the primary care doctor. Nobody thinks they have enough time, and it never seems like it's the right day, right? The academics, including myself, think that shared decision-making is the key to excellent care. Now, that's changed a lot in the years that I've been on the planet. I was born in 1951. Growing up, shared decision-making happened when the doctor shared his decisions with you, right? And it wasn't an opinion. It was like the doctor was just sharing this, translating the signs of nature. If the doctor said your father is dying, your father was dying. Nowadays, if I say that, somebody leans forward and looks at my name tag. So who the heck are you? I'm not taking this. I'm going to Cedars, wherever. Right? These days, we recognize that shared decision-making is about that partnership. Hopefully, we doctors come to the clinical encounter expert in the diagnostics and therapeutics of the patient's condition. But the patients and families are already expert in their personhood. They know what matters to them, what matters most. They know about their values, preferences, and priorities. Together, we can decide what the best care is at each point in time. Now, I'm not going to show you a lot of data today, but I have to show you this one study because I think it's emblematic. So here's a study from my colleagues and friends at Dana-Farber and Mass General. They did a study where they followed 332 patients with advanced cancer and their loved ones through the course of their advanced illness unto their death. And they analyzed data prospectively around a single question. Have you or your doctor discussed any particular wishes you have about the care you would want to receive if you were dying? For many of these people, it was a single conversation. Scrolling way forward, look what happened in the last week of their lives. Around that one item, if you had that conversation, you had a third the risk of ending up in the ICU. 12.4% if you hadn't had the conversation, 4.1% if you had. Being on a ventilator, 11% if you hadn't, less than 2% if you had. Having CPR performed, this is not code status. This is actually having CPR performed, was nearly 7% if you hadn't had that conversation and less than 1% if you had. And for those of you who are not clinicians, let me just tell you the hard truth. CPR on patients with advanced cancer does not work. It's inappropriate. It's extremely expensive, and it's really a terrible thing for clinicians as well as the patients. Patients are insensate, but clinicians feel terrible. This is a source of moral distress for a lot of doctors and nurses. And the chance of getting home with hospice rose by 1.5 times if you'd had that conversation. Now, doctors hate advance directives. They don't like to have these conversations. I have friends who say, clinical colleagues say, I don't know why you keep talking about this stuff. These documents never seem to help me, and it never seems to be the right time. It's not the right time when I've just diagnosed cancer and I'm trying to build their hope up, even if it's a severe cancer, a glioblastoma or a pancreatic cancer. It doesn't seem like the right day. Do you want me to have that conversation now? Well, I sort of do. Because it's never the right day. It's always too soon until it's too late. It's not the right day today. It's not the right day when they come back for their first infusion and they're worried about that. It's not the right day and they come to the hospital with neutropenic fever. It's not the right day if we're pre-oping them for surgery. It's always too soon until it's too late. But I can tell you 2 things that you can say to these patients that put a pin in the tension and really normalize having these conversations. The first thing you need to be able to say is, we ask this of everyone. This is not about your condition, your prospect for recovery. This is about our standards of care, because we think that it's important that we have these conversations and that at very least we know who you would want to speak for you, who you trust, in case you weren't able to speak for yourself. The second thing that needs to come out of the doctor's mouth is, I have an advance directive. And so does everyone in my family. If you want to lead the transformation of healthcare, let me say that you need to be able to say that in your own family, to your colleagues, to your patients, to your clients. I have an advance directive, and so does everyone in my family. I have an advance directive not because I have a serious illness, but because I have a family. And I know that if I have a car accident, a head injury, a stroke, my wife and my daughters are going to struggle around the decisions about my treatment and care. I can't stop that, but I can give them clear authority to speak for me so that nobody can challenge that, no ethics committee or judge can challenge that. And I can tell them what I think I would want if I were seriously ill, so that maybe I can lift a little bit of the burden that they're likely to feel as they wrestle with these decisions. I do have an advance directive, and so does every adult in my family. These are my 2 daughters, taken at a family party in 2005, spring of 2005. They were living apart. One was in college, one was already launched. Anybody remember what was happening in the spring of 2005 in this country? The Terri Schiavo case was happening. The country was convulsing. right? The governor of Florida had just signed a law that had been pushed through the Florida legislature to protect Terri Schiavo from a hospice program, a very good hospice program, that was being picketed by right-to-lifers, alleging that the hospice people were murdering Terri Schiavo at her husband's bequest. The President of the United States was flying from Crawford, Texas, to the White House to sign a bill that hadn't been pushed through Congress. During that spring, each of my daughters, it was in May, we had separate conversations. We're a pretty close family. And during those conversations, each of the daughters separately asked me, Dad, June's coming up, Father's Day's coming up. Anything you want for Father's Day this year? I want you to complete an advance directive. I said, the worst thing I can imagine is that you might be seriously injured or ill and unable to speak for yourself. But frankly, even worse than that, given what's in the news, would be having to deal with an ethics committee or, heaven forbid, a court or, God forbid, the United States Congress, and having to make decisions about your care. I said, if tragedy befalls our family, could we at least keep it in the family? I tell this story to medical students with some frequency, and they often laugh as you did. But think about it, because they think they're immortal, they're in their 20s. Think about it. Quinlan, Cruzan, Schiavo were all healthy young women. No diagnoses until a crisis occurred. And yet these are the cases that have framed our case law. Transformation is possible, but it's going to require understanding how big change happens and how it happens fast. We're living with change. And yet you know as well as I do that it's like trying to redesign a bicycle while you're on it, right? Our health systems are busy, and yet we have to do reform. We have to do redesign. We're changing workflows. The pace of change is dizzying. It keeps accelerating. Now, I'm here today, and I'd spend my days with geeks and wonks and policymakers working really hard through the granular details of trying to fix our measurement. I spend so much time on measurement and IT, trying to get quality measures right and then helping people succeed. We hope we're going to end up with something that looks like this. But you know as well as I do, we're in danger of something that looks like this, right? This is how sausage is made. We have an advantage. The reason that I'm actually hopeful is that things have changed. We're still laboring with a healthcare financing system that was invented when phones still had dials. And when healthcare systems were the de facto healthcare system in any community was a doctor's office. Phones no longer have dials. Healthcare is a highly matrixed, highly complex system of systems. But we've changed because we finally are starting to move from volume to value. You know all this. This started with Romney Care. Thank you very much. Became Obamacare, and now is in the ACA and Doc Fix, and Medicare has said this is the future. So all of us who are managing Medicare Advantage and Medi-Medis and population health are working through this. We're in two canoes now, but we're moving toward that second value-based canoe. That's a good thing. The challenge will be keeping the clinician patient in the mix here. We have a science now of health service delivery. That was given to us first by Avitas Donabidian, the father of healthcare quality improvement. Do you know who he is? He's the guy who reinvented, or reimported the Deming CQI model from Japan, where the car makers were using it. They called it Kaizen, and they were using it to very effectively compete against Detroit. Donabidian reimported it, and he said, we can do this. He said, we need detailed information about the causal linkages among the structural attributes in the settings in which care occurs, the processes of care, and the outcomes of care. That structure, process, outcome model we're still using today, the science of healthcare quality improvement. Now, I don't have time to talk about a lot of what we're doing at Providence today, but let me say that we've put together a non-incremental change package that addresses crossing this quality chasm quickly, because we don't have 20 years to do it. So we have defined standards of quality that include the expectation that care will be goal-aligned, that there will be documentation in the medical record of good faith efforts to elicit and respect the values, preferences, and priorities of the people concerned. Absent that documentation, I don't know whether care is good or bad. I don't know whether it's aligned with what people actually want and what matters most to them. We're measuring and monitoring it, and then we're making it easy to excel. We want to make excellent care the new normal, whole person care the new normal. Just to give you a taste, and it's only a taste because I want to come back and talk further in future years about what we're doing. But we've said, you know, in order to call palliative care in one of our hospitals a program, it ought to have at least minimum specifications for how often it's open, what services it provides, and the staffing level, right? One nurse practitioner and a third-time doctor and a borrowed social worker and chaplain do not a palliative care service make. That's ersatz. Let's be honest about it. I said to the leadership, if you're really serious about goal-aligned care and want to push this through policy and through, you know, health system quality improvement, let's do it for ourselves. We insure over 70,000 employees and their spouses. Why don't we incentivize them to have these conversations? In a single meeting, the leadership said, wow, that makes entire sense. Yeah, let's do that. Within 6 months, we announced a health incentive plan started in September where each employed person, either employee or their spouse, can get $700 in their health savings account or $400 in their managed care account simply by watching a brief video about advanced care planning, filling out an 8-item reflective survey, and promising to do something with that information. Just talk to their spouse, talk to their doctor, look at their previous advance directive and make sure it's still current. You know, we were worried, or at least some of us were worried, at how this would go down. Turns out that our employees loved it. 93% of them chose this option, although they had a more traditional option about health risk assessment and your BMI and, you know, all that. 93% chose this. 81% thought it was helpful, would want to do it again. As I come, you know, to meet new patients, as we care for patients with serious, incurable conditions, people facing the end of life like Steve Jobs, alleviation of suffering is our first priority, but it's not our ultimate goal. You know, yes, it's important that we get it right, how people are dying, but I want you to know that there isn't, you know, I don't know, you never hear me say the word good death or the phrase good death, because I don't know what a good death is. Death is beyond life. It's a lifeless state. Dying, however, is a time of living. And people can die well. Not well as an adverb like it's the right way to do it, but they can die with a sense of well-being. I'm here to tell you that as a clinician who's cared for seriously ill and dying people for years. But you know that if you just are attentive to the literature. Remember this guy? Our colleague Oliver Sacks died recently, remarkable neurologist and author. Shortly after he got the diagnosis that his ocular melanoma had recurred and was now metastatic and would shorten his life, he wrote a piece for the New York Times. In it he said, quote, "It is up to me now to choose how to live out the months that remain to me. I have to live in the richest, deepest, most productive way I can. Over the last few years, I've been able to see my life from a great altitude, as a sort of landscape, with a deepening sense of connection of all of its parts. This does not mean I am finished with life. On the contrary, I feel intensely alive. And I want and I hope that the time that remains to deepen my relationships, my friendships, to say farewell to those I love, to write more, to travel if I have the strength, to achieve new levels of insight and understanding. This will involve audacity, clarity, plain speaking, trying to straighten my accounts with the world. But there will be time, too, for some fun, hopefully even some silliness. I feel a sudden clear focus and perspective. There is no time for anything inessential. I must focus on myself, my work, and my friends. I shall no longer look at NewsHour each night. I shall no longer pay attention to politics or arguments about global warming. This is not indifference, but detachment. I cannot pretend I'm without fear, but my predominant feeling is one of gratitude. Above all, I have been a sentient being, a thinking animal on this beautiful planet, and that in itself has been an enormous privilege and adventure. This man was living during the time what we would consider him to be dying. So let me suggest that this is one crisis we can solve, and we all who do policy work, do have a role in it. We can up-level the goals that people think about in America when they're facing the end of life. Yes, people should be able to die without suffering, die without agony. We have the capacity to do that if we teach doctors to do it and we routinize excellent palliative aspects of care, whether they get palliative care through the discipline and service line or not. We can help people to complete their life, not just die comfortably. Just make sure there's nothing critically important left unsaid. We can help them die well with a sense of well-being. Notice that Oliver Sacks had a sense of well-being, even though he knew full well that his life was short. We can affirm people's inherent dignity so that even if they're physically dependent, they can see their inherent dignity reflected in our eyes, feel it in the way they're touched. And we can help families to honor and celebrate their loved ones during this difficult time. Policy, yes, it's going to take some political will. It's going to challenge us all. But we can do things. Here are things, and this is just, I'm speaking as an individual, as somebody who's been writing about this, speaking about it for years. We need to dramatically raise standards of education for physicians and nurses and other clinicians in training. It's ridiculous that we still teach more obstetrics to medical students than we teach hospice and palliative medicine. That's got to change. There's plenty of time in medical education to get it right. We need to establish parameters for what you can call a palliative care program so that the public, all of us, can know that when there's a palliative care program that it has certain things. You wouldn't call a cardiology program if there was a nurse practitioner and a third-time cardiologist on call. Let's be real. We ought to require palliative care consultations for people with dementia going to, aortic valve surgery, or people receiving low-yield chemotherapy. It ought to just be part of enforcing a goal-directed, goal-aligned approach so that what we're giving them, we know that they actually want. We need to eliminate, this is a federal one, but we need to eliminate the ridiculous requirement that you have to give up treatment for your cancer, your heart failure, or your COPD to get hospice care for your comfort, your quality of life, and support for your family. SB 1004 came close to this for Medi-Cal patients, but it hasn't been, the regulations have yet to be written. That needs to be accelerated. We need to ensure that there's adequate staffing in our long-term care facilities. While there are excellent exceptions to, and really good long-term care facilities to point to out there, they're very rare. Most long-term care facilities are understaffed. And many long-term care workers, the nurses and particularly the aides, aren't really making a living wage. That's got to change. These people are heroes in America today, and they deserve to be cared for. We need to yank the licenses of the lowest performing nursing homes. Why do the one-star nursing homes continue in existence? They shouldn't have the privilege of caring for our grandparents and our parents. Why don't we just yank it and give new licenses to the excellent models of nursing care that we know are out there, that have been proven effective? The Eden alternatives, the Beatitude models, the greenhouse models, you get it. People are, I'm sure, thinking, well, yeah, but you can't get this through anything. I mean, we're so fractious. There's so much political controversy these days. But remember what happens when a disaster strikes. When a natural disaster strikes, we come together. This is where I grew up in New Jersey. You can probably hear it from the pace of my talk. I grew up in Asbury Park, New Jersey. This is from Asbury Park, New Jersey in the September of 2012 when Hurricane Sandy struck. This was just before the presidential elections in November of 2012. But we saw people come together, get into the raft. People didn't ask, well, who are you voting for before you get into the raft? Right? Are you a Democrat or a Republican? Are you a social conservative or a social progressive? Right? We just got into the raft. Everybody moved to higher ground because it's the right thing to do. When a natural disaster strikes, we're all in this together. In fact, even these people came together. Right? This is not a bromance that lasted. But in this moment of time, in the face of a national crisis, of a natural disaster, they came together to do the right thing, the caring thing. Folks, let me just say that death is the natural disaster that awaits us all. In the face of our mortality, our shared mortality, we could come together and get this right. And finally, as I close, let me suggest that this is not just about politics. It's not just about health service reform or health service research. We can't do this well if we don't do it with heart, if we don't do it with love. In fact, Francis Peabody, this is a quote you probably know, said years ago, "One of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient." Engelbert Dunphy, one of the most important surgeons of the 20th century, chief of surgery at UCSF, reflected on that quote, that famous quote, years later. He said, "Francis Peabody's dictum permeated our student days at Harvard. We learned that the practice of medicine is cold and abrasive unless tempered by love." And remember Don Abidian, the father of healthcare quality improvement. Well, when he was living with and dying of prostate cancer, he was interviewed for Health Affairs by Fitzhugh Mullen. He said, "Systems awareness and systems design are important for health professionals, but they're not enough. They are enabling mechanisms. It is the ethical dimension of individuals that is essential to a system's success." He said, "Ultimately, the secret of quality is love. You have to love your patient. You have to love your profession." He added, "You have to love your God." If you have love, you can then work backward to monitor and improve the system. So that's where I'll leave it. We have the opportunity of getting our language right, understanding that illness is not fundamentally medical, it's fundamentally personal. We can contribute to the ongoing evolution of our healthcare systems and our society. Creation didn't end, it's ongoing, right? We're creating the future. We need to do it with intelligence, with sophistication, with methodologic crispness, but also with love. Thank you all for the work that you do day in and day out. I hope I get to partner with you in creating a world that I can leave to my children and grandchildren, and so can you. Thank you.
Dr. Ira Byock, thank you very much. I appreciate it.
It's a pleasure. Pleasure to be with you all.
I just will ask you one question for a 30-second answer.
Yeah.
Some people might argue that money is important in healthcare.
Yeah.
Some people might argue that healthcare is all about money. Where do you align money and love, or are they separate?
We are in a remarkable period of time where doing the right thing is actually the fiscally smart thing to do. You know, the data is absolutely clear that these goals of care conversations result in people getting higher quality on their HCAHPS and on every standard, but also lower per capita costs. Yeah. The business case is clear. If you have these conversations in the ICU, not only are the costs go down, but the throughput goes up, so you can actually fill those beds with people who need to be there. Money is not the obstacle anymore, not at the moment. We just have to align what we know is right with our policies and procedures. This is one crisis we can actually solve.
Let's give them one more round of applause.
Thank you all very much.